Good morning. Let's get started with our program this morning. First, we'd like to welcome our applicants to our general surgery residency program today. I'm Ken Sarenic, one of the senior professors and vice chairman of the department, and I kind of moderate and run grand rounds and the morbidity mortality conference to follow. Today we have one of our chief residents, Dr. Susannah Nicholson, who will be presenting on inguinal hernia. I assure you the dummy was not meant for you. I could pick out several residents who that was directed towards. Dr. Nicholson grew up in Virginia, is a graduated from Duke undergraduate. No, she did not play on the basketball team, for sure. She then is a graduate of this medical school. And then has been in our general surgery residency for the past 7 years. She spent 3 years in the lab doing research and received a master's of clinical investigation. And she has been accepted in our trauma and critical care fellowship here beginning in July of 2013. Please help me welcome Dr. Nicholson.
Thanks, Dr. Cernick. I actually did play basketball at Duke. I played intramural basketball, and actually we were in the championship game and got to play in Cameron. So, believe it or not. Welcome to all the applicants. Again, my name is Susannah Nicholson. I'm one of the chief residents. And I will be talking about inguinal hernia today. Objectives for my talk: I'm going to give a brief overview and talk about history, a review of the anatomy. I'm going to talk about open versus laparoscopic repair, a TAP versus TEP, and I'll explain the acronyms. Complications of hernia repair: the acutely incarcerated hernia, a sliding hernia, Richter's hernia, femoral hernia, obturator hernia. And I actually will not cover sports hernia today. So to give you a brief overview, I mean, this is a lot of this is going to be review for most people in the audience, but this is actually a topic that comes up a lot on our AB site, and it comes up on our board exam. And it's something that everyone kind of takes for granted that you know, but when you really start delving into inguinal hernia, the anatomy is pretty complex, and the repairs can be complex. And it's something that people end up missing on in-service exams and on board exams. So we're just going to kind of go over everything today and talk about some of the more controversial topics. So inguinal hernia, as you know, is more common in men. Only about 2% of women in their lifetime will get an inguinal hernia. And there are about 750,000 inguinal hernias repaired a year in the United States. An indirect hernia goes through the internal ring in children, and it's thought to originate from a patent processus vaginalis. However, in adults, there might be an element of this as well, but it's also thought that in adults, there's a widening and weakening of the internal ring from some unknown mechanism that also contributes to an indirect hernia. For direct hernias, these are through the posterior wall of the inguinal canal, and they go through Hasselbalch's triangle. The area is only composed of fascia. It's the transversalis and aponeurosis of the transversus abdominis. There's no true muscle. And they're from increased intra-abdominal pressure, and they're primarily in men. A pantaloon hernia has direct and indirect components. And then I'll touch on this a little bit later, but femoral hernias mainly occur in women, and it's thought that women have, especially in women that have a broad, flat pelvis, coupled with medially shifted insertion of their iliopubic tract, and this widens the orifice of the femoral canal. You can often see a femoral hernia by a bulge in the medial thigh or below the inguinal ligament. A little bit of history. Hernias have been described dating back to Babylon and in early Egypt, and these are pictures of early trusses. I'm not really sure I would want this done, but this is a picture of taxis for reduction of an incarcerated inguinal hernia, probably around the medieval time period. And Eduardo Bassini is considered the father of modern-day hernia surgery. And, we still, as you know, we have the Bassini repair, and that originated from him. And he combined a high ligation of the hernia sac with reconstruction of the inguinal floor. And he was able to reduce recurrence and morbidity significantly. And this was really what allowed people to truly start wanting to have their hernias repaired. Prior to this, it was not recommended because of the results were so poor. A few other people are mentioned here just with various accomplishments. Marcy he published the first paper on aseptic hernia repair. Zerny, and I'm sure I'm mispronouncing that, described ligating and excising the indirect hernia sac through the external ring. And Coker twisted and then transfixed the peritoneal sac in the lateral muscles through the external ring. And this was all going on in the 1800s, and there are a few more developments there as well. So to review the anatomy, we'll start with just the basic abdominal wall anatomy. So above the arcuate line, the internal oblique and the external oblique come together. Their sheaths form the anterior layer, and this is, I'm looking at this, and this should be switched, but, and then the internal oblique and the transversus their sheath forms the posterior layer to the abdominal, behind the rectus. This is all above the arcuate line. Below the arcuate line, all three muscle layers, again, these should be switched. The external should be the most superficial. But all three muscle layers, the aponeuroses, come anterior, and it only leaves the transversalis fascia in the posterior layer to the abdominal wall. The inguinal canal is an oblique canal that's approximately 4 centimeters long at the inferior margin of the anterior abdominal wall. The deep internal ring is the entrance through the transversalis fascia, and it's lateral to the epigastric vessels. The superficial ring exits through the external oblique aponeurosis, and the boundaries of the canal are anteriorly the external oblique aponeurosis, the posterior wall is the transversalis fascia laterally, and medially is the internal oblique and the conjoint tendon. And the conjoint tendon is the joint insertion of the aponeurosis of the internal oblique and the transversus abdominis. The roof are fibers from the internal oblique and the transversus abdominis, and the floor is made up of the inguinal ligament that's also reinforced medially by the lacunar ligament. The contents, as you know, in men, the spermatic cord, the round ligament in women, and the ilioinguinal nerve, blood, and lymphatic vessels. This is a good illustration, of the abdominal layers in this area, and how how bowel can slip in through and cause an indirect hernia. This is again, the external oblique. This is the internal oblique. This hook is around the internal oblique, and the cremasteric fibers are coming from the internal oblique. And then this hook is retracting the transversus abdominis muscle there. Again, another picture, and I mainly put these up because when you're reading about repairs and preparing for cases as a resident, there are all these ligaments, and there's the lacunar ligament, there's Cooper's ligament, there's Poupart's ligament, and just trying to figure out where these ligaments are oriented and where they are anatomically and kind of in a three-dimensional plane is sometimes difficult. And then when you actually are in the operating room, it's not always apparent or clear exactly where some of those ligaments are. A lot of times it's like, oh, well, just sew this stuff to this stuff. But this is an inguinal, this is the inguinal ligament, which is also the Poupart's ligament. The lacunar ligament is right here. And the conjoint tendon is, again, coming down, and it's connecting down into the pubis, which is different than the conjoined tendon. There's also, and I'll get to that in a minute, but I think it can be kind of confusing. The conjoint tendon is different than the conjoined tendon. And again, just a few other ligaments that come up frequently in discussing repairs. So here's, again, the conjoint tendon, the inguinal ligament right here, or Poupart's ligament. The lacunar ligament you can see is right here. And the pectineal, or Cooper's ligament, is, if you follow this down, right back in here. And it's more posterior. A hernia discussion would not be complete without talking about Hesselbeck's triangle. This is a frequent PIP question for medical students. The boundaries are the laterally, the inferior epigastric vessels, medially, the lateral border of the rectus, and inferiorly, the inguinal ligament. And a direct hernia, as we mentioned, goes through Hesselbeck's triangle. An indirect hernia is lateral to Hesselbeck's. And the femoral canal, and again, this will be important when we talk about femoral hernias. Superiorly is the inguinal ligament, and inferiorly is the pectineal ligament, or Cooper's ligament. Medial is the lacunar ligament, and this is a posterior view, and then lateral is the femoral vein. So to talk about some of the repairs, open versus laparoscopic. So I'm mainly going to talk about, in terms of the non-mesh repairs for open hernias, I'm mainly going to talk about the Bassini, the McVeigh, and the Schuldeis. Those are the main ones that are used today. And with mesh, we mainly use the Liechtenstein and the plug and patch. Laparoscopically, there's the transabdominal preperitoneal and the totally extraperitoneal repair. So a Bassini is basically we reduce and ligate the sac, and the transversalis, a key component of a Bassini repair is opening the transversalis fascia from the internal ring to the pubic tubercle. And in doing this, Bassini prepared what he called the triple layer, which was comprised of the transversalis fascia, the transversus abdominis, and the internal oblique. And often today, we don't really, when we do a Bassini, a lot of times we don't open the transversalis fascia, and a lot of times those three layers are kind of grabbed together, and what we often refer to as the conjoined tendon, not the conjoint tendon. And that becomes the medial wall that we sew to. Then the triple layer is then sewn to the pubic tubercle and the reflected inguinal ligament. And the internal ring is closed on the medial side. And also of note, the Bassini repair does not have a relaxing incision. Originally it did not. Some people have modified it to include a relaxing incision. The McVeigh repair is actually pretty useful today. There are a lot of times that we have to repair a femoral hernia, and people will choose to do a McVeigh repair. So it's a good repair to have in your toolbox when you are faced with a femoral hernia. It's similar to the Bassini. It uses Cooper's ligament instead of the inguinal ligament for the medial part of the repair. And interrupted sutures are placed from the pubic tubercle laterally along Cooper's ligament, and they progressively narrow the femoral ring. And then there's a transition stitch, and this is kind of what is also important. And it's the last stitch in Cooper's ligament, and then you transition and include the inguinal ligament. So this completes the narrowing of the femoral ring, and it provides us a transition to the inguinal ligament over the femoral vessels. And this is so the repair can be continued laterally, as in a Bassini. This, however, there's a lot of tension with this repair, and you have to do a relaxing incision. And the tension, a lot of times we don't do this as much because, or this repair as much because the tension from this can result in a lot of pain and discomfort to patients, and it predisposes patients to recurrence. The Schuldeis repair, or a lot of us still do this over at the VA on a regular basis. Dr. A isn't here, but we do this a lot with Dr. Aberjali at the VA. This, for a long time, was the gold standard, but it's a very complex repair, and it can be difficult to teach, and so and a lot of times there's difficulty in understanding what layers are being sewn to what. The importance is placed on freeing of the cord, resection of the cremasteric muscle, and high dissection of the hernia sac, and then division of the transversalis fascia. As opposed to the previous two non-mesh repairs, the Schuldeis repair sort of centers around a running stitch, and this is believed that it helps even out the tension and that it helps prevent recurrence between the stitches. There's force in the traditional Schuldeis repair. There's 4 suture lines. A lot of people now will modify it to 3 suture lines, and basically you begin sewing medially, and then you sew out towards the internal ring, and then you basically sew back. But each time, so that you're kind of becoming more and more superficial as you go, and it basically shifts the internal ring so that it's no longer where the hernia was, and it approximates, again, the full thickness. You're approximating that full thickness internal oblique and transversus abdominis to the external oblique, and each time you're kind of getting a more superficial layer. And then the Liechtenstein is what a lot of us do these days, and it's kind of become the gold standard. It's basically our standard mesh repair. Generally, we don't open the transversalis fascia. The key is placement of a large piece of mesh, or large enough that the repair is tension-free, and it extends from the pubic tubercle to the anterior superior iliac spine. You secure it to the shelving edge of the inguinal ligament and medially to the internal oblique and rectus. The plug and patch is similar in that you place the mesh, but prior to doing that, there's a plug that is placed into the defect, and you can fix it to the internal ring in an indirect hernia, and you can fix it to the neck of the defect in a direct hernia. And then the mesh is then placed and sewn on top in the manner of a Liechtenstein repair. So mesh versus no mesh. Several Cochrane database reviews have looked at this, and actually a fairly recent one actually compared the Schuldeis technique to other open techniques, and they included 16 trials. There were a total of 2,566 hernias in the Schuldeis group, and they did find that their recurrence rate was a lot higher than repairs that used mesh. However, of the non-mesh repairs, it was by far the most superior, and there was no difference in chronic pain, complications, or post-op stay. So there are times when you can't place mesh, when you have, for instance, an incarcerated hernia with, when you have a bowel that doesn't look good. You don't want to put a piece of mesh in a really sick patient like that, but you need to fix the defect. You can use, this would probably be your best option. Again, an older review also compared mesh versus non-mesh, and found the same thing, that there was fewer recurrences with the mesh compared to the non-mesh. Basically, you reduce your recurrence by 50 to 75%. and then there was no difference in mesh alone versus plug and patch. Before we talk about laparoscopic repairs, you have to kind of switch the way that you view the anatomy with a laparoscopic repair, because you're looking at everything from the inside out. And there are certain structures that you really have to pay attention to. This is a picture, again, you're looking kind of from the inside of the abdominal wall outward. And here are the external iliac vessels and the femoral ring, the external ring and the internal ring, and the femoral nerve. And this is the femoral branch of the genitofemoral nerve, and this is the lateral cutaneous branch. So it's important to know that there's two main areas that you have to be concerned about. This is the triangle of pain, and so you can see this is where all those big nerves are. And you have to be careful when you're tacking in your mesh that you don't tack, because this is the iliopubic tract, and you have to be careful where you tack your mesh so that you don't entrap these nerves, because that's when patients have a lot of pain postoperatively. This is the triangle of doom. I think it would probably be better to hit the triangle of pain. But obviously you don't want to put tacks for your mesh in this area either, in your femoral vessels. A TEP repair is a totally extraperitoneal laparoscopic hernia repair. The benefits to doing a TEP repair are that you do not enter the abdominal cavity. You can reduce the risk of complications involving intra-abdominal structures. You're less likely to injure the bladder or the bowel. It maintains an intact peritoneal layer between the mesh and the abdominal cavity. And this can be placed without fixation, although generally people will put several tacks in. However, the learning curve for a TEP is much steeper than for a TAP. And the steps, the broad steps, are development of the preperitoneal plane. And this is usually done with, you make an incision, infraumbilical incision, insert your camera, and you can use a balloon system to, I have a picture of it here. You use a balloon system to create the space to allow yourself your dissection plane. And then this is an illustration showing where the trocars are usually placed for a TEP. And then again, this another picture of the posterior, of the anatomy looking into the abdominal wall. So again, trocar placement, dissection. Then you begin with dissection of the hernia sac. And it's important to identify the pubis, Cooper's ligament, the iliopubic tract, and the inferior epigastric vessels to orient your dissection. And you've identified the sac and contents that you have to dissect away from the defect and their swept cephalad. The next step is mesh placement, and the mesh is often contoured to the inguinal region, and it's manipulated to cover the pubic tubercle, the internal ring, and Cooper's ligament. It can be tacked to Cooper's and the anterior abdominal wall. This is kind of hard to see, but this is the inside of the balloon. You're looking through the balloon into the peritoneal, or to the dissection plane. And this is the initial dissection after the balloon dissection. And the balloon has been used, again, this is another picture of the initial dissection. Here it's developing that window. And I apologize for the quality of the pictures, but this is a picture of the sac, and it's being pulled down. This is, again, a picture of the mesh placement, and then you can see how the mesh is tacked up against the abdominal wall. This is just another picture of a view of a large direct right inguinal defect. A TAP repair, or transabdominal peritoneal repair, benefits are that it's a lot easier to learn, and the trocar placement, so the steps are trocar placement and pneumoperitoneum. So again, you enter like you would for any laparoscopic procedure. And then it's very important to identify your anatomic landmarks, which are the spermatic vessels, the medial umbilical ligament, inferior epigastric vessels, and the external iliac vessels. And then you create a peritoneal flap, dissect your hernia sac, and then you really want to go back and re-identify everything because of those pictures I flashed up earlier of the triangle of pain and the triangle of doom. You want to make sure you know where you are before you're putting in your mesh. So then when you've identified everything, you go ahead and you put in your mesh. You fix it superiorly to the rectus abdominis and the transversus abdominis and inferiorly beginning at the pubic tubercle, and you move out laterally along Cooper's. And then you close the peritoneum and the fascia in the skin. So this is a creation of the peritoneal flap, dissection of the peritoneum. You can see kind of in through here. Transversalis fascia, and then this is the hernia. These are a little bit, and they're dissecting out the hernia sac. And then again, re-identification of your landmarks. So you can see your epigastrics, and you find your ilio-inguinal ligaments and Cooper's, and then you can proceed with your mesh placement. So TAP versus TEP. Is there really a difference? A 2005 Cochrane database systematic review, they basically found that there's not enough data to really say. They were only able to come up with one randomized trial, and there were several others that weren't randomized basically. 8 non-randomized studies showed that TAP actually had a higher incidence of port site hernias and life-threatening visceral injuries compared to TEP. But again, it wasn't a randomized trial, and there was no difference in vascular injuries or deep mesh infections. So other studies have shown TAP has had a higher recurrence rate. A more recent study, again, they still had trouble finding enough studies out there. This was another meta-analysis comparing randomized controlled trials, and they also had trouble really coming up with enough numbers enough papers that actually compared TAP versus TEP. There were a number that compared TAP versus open or TEP versus open, but not a lot of them didn't have the actual comparison between the two. So, however, from their data, they found that there was equivalent operative time, post-op complications, and post-op pain, and then the time to return to work and recurrence was also similar. TAP was associated with a slightly longer hospital stay, and TEP had higher number of conversions to another procedure. So getting back to open versus laparoscopic. There's been a lot of controversy over this over the years, and it's kind of changed, I think, as people have gained more experience in laparoscopic inguinal hernia repair. This study was in the New England Journal of Medicine, and it was done in 2004. And this is a study you'll see quoted in textbooks. And this kind of also shows why textbooks are not necessarily the best source of up-to-date information. But it was a multi-center randomized controlled trial. It was 12 VA hospitals. They had great numbers in their study. 994 patients received an open repair, and 989 had a laparoscopic repair. And they primarily were their primary outcome that they were looking at was hernia recurrence within 2 years. And they found that laparoscopic hernia repair was associated with a higher rate of recurrence, 10.1% versus 4.9%. It was associated with more complications, intraoperative complications, immediate post-op complications, and life-threatening complications, as well as there were several deaths, whereas in the open repairs there were no deaths. And this did not hold, though, for recurrent hernias. And the recurrent hernias included in the study, they had similar recurrence rates. However, they did find that there was less pain with laparoscopic repair, and patients returned to their usual activities a day sooner than patients with the open repair. Also part of this study, they did a post-hoc analysis of surgeon experience, and again, this kind of goes back to what I was mentioning earlier, that recurrence rates were consistently higher for surgeons that had under 250 lap hernia repairs. And this was TEP and TAP both included. However, they didn't really feel that they had the numbers to draw strong conclusions from that part of their study, but they did show that experience seemed to matter. In 2003, also around that time, a Cochrane database systematic review, they found 41 randomized trials, and they showed, though, that there was no difference in recurrence for lap versus open mesh repair, and that the laparoscopic repair was associated with a faster return to usual activity, and there was less pain and numbness. More recently, this study was done in 2010. It was the LEVEL trial, and this specifically compared a TEP repair, because this tends to be what a lot of surgeons do these days, versus the Liechtenstein open repair. And again, this was a multi-center randomized controlled trial. There were 6 hospitals, 660 patients were randomized to the Liechtenstein or the TEP group. And the primary outcome were, instead of their primary outcome was not recurrence, they looked at post-op pain, length of hospital stay, period until complete recovery, and quality of life, whereas their secondary endpoints were recurrence, operating time, complications, and chronic pain and cost. And they found that TEP was associated with more adverse events during the surgery and longer mean operating times, but TEP had less post-op pain and a faster recovery to daily activities and quicker return to work. Recurrence, they found, was similar in both groups. And they also looked at experience, although they didn't really have their surgeons perform as many cases as the previous study, but what they basically looked at was that there were, they kind of ranked the experience level, that in order to be included, they had to have been part of at least 100 lap procedures and a minimum of 30 lap hernia repairs. Someone that had met those criteria had to be in the operating room. But they, as few as 10 hernia repairs, they ranked them on 3 levels. And they found that there were more recurrences and second operations on patients that had less experience with the laparoscopic repair. So again, this is the data that I came across tended to say that they were best in recurrent inguinal hernias. With bilateral inguinal hernias, also laparoscopic is optimal. There's a longer OR time, but shorter recovery time, decreased incidence of persistent numbness, decreased risk of wound infection, and there's no difference in recurrence. Again, that goes back to meta-analysis, a Cochrane database systematic review in 2003. Complications. So this is actually an ABSITE question from last year. Pain is the main complication, as high as 53% incidence. And it's more common in young patients and patients who report that their pain prior to the repair is attributed to their hernia. The ABSITE question comes with, it was actually how you treat, the best initial treatment for post-operative pain from a hernia. And it's reassurance and conservative therapy with NSAIDs and local nerve blocks. Urinary retention is another complication. Wound infection, testicular atrophy, which results from compromise of the testicular blood supply and the thrombosis of the veins supplying the testicle. Ilioinguinal nerve injury from an open repair, and then recurrence, laparoscopic injury to the femoral branch of the genitofemoral nerve, the lateral cutaneous nerve, and femoral artery. And there's also visceral injuries to bowel and bladder. The the acutely incarcerated inguinal hernia. So just to straighten out, incarceration, as everyone knows, is hernia content is trapped and unable to be reduced. And strangulation is ischemia and necrosis of those trapped hernia contents. Emergency surgery is more frequently needed in women than men. With an acutely incarcerated inguinal hernia, you can repair them through a groin incision. Generally, open is considered better than laparoscopic, although there's some data to suggest that you can do it laparoscopically. But the important thing is that you need to evaluate the bowel. If the bowel appears gangrenous or dusky at all, you need to go ahead and potentially need to do a laparotomy. A lot of times that is strongly indicated, but depending on the extent of the bowel injury, sometimes you can do that through a groin incision, but it's probably best to go ahead and do a laparotomy. Mesh can be used if the hernia tissue looks normal or is slightly edematous. However, if there's just really significant edema or dusky or gangrenous bowel, it's, again, best not to put mesh in. And this goes back to what we were talking about earlier, that you need to have you need to be able to do some of those open repairs that don't involve mesh. Sliding hernias are when a portion of the sac composed of the mesentery of the viscera or the viscera itself, involving the ovary, the fallopian tube, cecum, appendix, sigmoid colon, bladder, ureter. The mesenteric vasculature and the enteric organ are only covered with the peritoneum, and then the serosa on the inside of the sac. The outer surface has been extraperitoneal prior to the herniation, and so it doesn't have a peritoneal or serosal layer. So when you repair these, it's important to separate the sac and peritonealize the extraperitoneal surface, and then you can complete this with a Lichtenstein repair. This kind of goes through the steps and how you would peritonealize that extraperitoneal portion. A Richter's hernia is when only part of the circumference of the bowel is caught in the hernia. The hernia defect is large enough for bowel to enter, but small enough that whole bowel cannot protrude. And there's a tight ring. And if there's a tight ring, it can lead to strangulation. So the most common site is the femoral canal, and a lot of times it can be mistaken for a large lymph node. Intercutaneous fistula can be seen with delayed presentation, and you can repair these as you do with other inguinal hernias. Now for femoral hernia, and this is another topic that comes up on the ab site a lot. It's a hernia through the femoral ring. It's less than 10% of all groin hernias, and 40% present as emergencies. Again, it's in women that have a broad, flat pelvis and medially shifted insertion of the iliopubic tract. And often presents as a bulge in the medial thigh or below the inguinal ligament. That's a key point. There's high risk of incarceration or strangulation, so it's very important to repair these. Classically, a McVeigh has been used, but and you can't do a Lichtenstein. You can do a bilayer mesh repair that combines a Lichtenstein with a preperitoneal repair. So you access that preperitoneal space by opening the transverse salus fascia, which we don't usually do in a Lichtenstein. And then the herniated tissues from the femoral ring, you reduce those tissues, and and another difference is that you leave the sac in place. And then part of the mesh can be placed in that preperitoneal space, and then the anterior component is sutured in as you would with a Lichtenstein. And again, here's just this picture again of the femoral canal. So this is where the hernia would occur. This is showing a bilayer mesh repair. So again, this is kind of showing where the mesh would be, and it's in that preperitoneal space down here, and then sutured up anteriorly to the abdominal wall. An obturator hernia, again, another favorite topic on the ab site. This is very rare. hernias through the obturator foramen. It's more common in women, especially older women who've had a lot of kids. The diagnosis is frequently made when you're in their belly for an XLAP for a small bowel obstruction. And it can be fatal if it's left untreated. The classic sign is a Hallschip-Romberg sign. And this is pain in the medial thigh and hip. It radiates often down to the knee on extension with medial rotation and abduction. And this is caused by the hernia compressing the obturator nerve. There's several different ways, and if you're in their belly already, you can do a transperitoneal approach, and you can close that defect primarily around the obturator vessels with a running suture. You can also, mesh can be sutured to Cooper's if it's a clean case. And then you can also do, if you've happened to discover this before you're operating on someone for a bowel obstruction, you can do an extraperitoneal or a thigh approach. You can even, so it's been described to do TEP versus TAP. Again, this is a picture of the obturator canal. And I just thought this was kind of interesting in terms of a thigh repair if you were ever to do that. But they also it's very important to examine the bowel and make sure that the bowel appears healthy. And if it doesn't, then you're probably going to have to explore them in their belly. Just to summarize kind of some of the main topics, mesh is superior to non-mesh. If no mesh is used, a Schuldeis is the best non-mesh repair. There's no difference in recurrence for open versus laparoscopic repair. And however, there is it does seem to be dependent on experience. And there's a decreased pain for laparoscopic repair, but a higher chance of complications. Laparoscopic repair is better for bilateral and recurrent hernias. And then there's insufficient data really to say if TAP versus TEP is better. So just a quiz, because I know that you're probably all falling asleep right now. I will buy a cup of coffee for anyone that gets a cup of Starbucks coffee. For anybody, so that's for anyone that can answer these questions. So, a cup for each question. Generous. Okay, so an indirect inguinal hernia is repaired laparoscopically by stapling polypropylene mesh over the defect. The complication of this repair most frequently associated with significant postoperative pain is A, recurrence of the hernia, B, entrapment of the ilioinguinal nerve, C, formation of a hydrocele in the sac, D, erosion of the mesh into the intestine, E, entrapment of the lateral femorocutaneous nerve. Do I have any takers? You got to raise your hand because I can't. What? E? Yes, Jackie gets a cup of coffee. You got to keep track and remind me. The next question. Testicular atrophy following inguinal hernioplasty is usually due to A, damage to the external spermatic artery, B, subacute orchitis, C, thrombosis of the veins in the spermatic cord, D, damage to the testicle from mobilization, and E, ligation of the vas deferens. I saw your... Yes. Okay. You'll have to see me afterwards on. Next question. An 82-year-old woman has abdominal pain, nausea, vomiting, and groin pain. Which of the following statements is true? A, manual reduction should be attempted after conscious sedation. B, an inguinal approach to repair will require incision in the inguinal floor, or the transverse fascia. C, pelvic examination is likely to show a defect in the obturator canal. D, pain upon extension and adduction, followed by medial rotation of the thigh, Hallschip-Romberg sign, is frequently present. The lateral aspect of the defect is bordered by the lacunar ligament. Takers? Dr. Perry?
B.
Yes. Get a cup of coffee. A 60-year-old woman has fever, abdominal distension, bilious vomiting, and a tender mass below the right inguinal ligament. The most appropriate initial management is A, immediate operation through a suprainguinal groin incision, B, immediate operation through a midline abdominal incision, C, nasogastric suction, intravenous antibiotic therapy and observation, D, immediate operation through an infrainguinal thigh incision, and E, intravenous sedation and attempted reduction of the hernia. Correct. Ramon gets a cup of coffee. Next question. A patient with an obturator hernia is most likely to present with A, bowel obstruction, B, sharp pain in the perineum, C, pain on urination, D, hematuria, E, dull pain in the lateral thigh. Yes. If you were listening, you could easily get that one. Thank you.